Welcome to the School of Population Health in Perspective seminar series. I'm Rebecca Ivers, Head of the School of Population Health here at UNSW, and I'm delighted to welcome you all to this very important topical panel discussion. I'm coming to you today from the land of the Gadigal Wangal people in Sydney, Australia, and I'd like to acknowledge the traditional owners of all the lands we meet on today, pay my respect to elders past, present and future, and acknowledge the strength and richness of the most ancient and enduring culture on the planet. Today, you'll hear from a powerful array of speakers from across the globe talking on vaccine equity. As we stumble through this COVID-ridden landscape and find a pathway out, there are many people who've been left behind. Today, we'll seek to explore how we better address this and develop pathways to health for everyone. We have a very strong focus on health systems and on equity here in the school, and the issue of vaccine equity is one of the most pressing global issues the world has to deal with. As high-income countries, including Australia, gaze inwardly and work to keep their populations safe, there's a moral imperative to ensure that this isn't at the expense of lives either here or elsewhere. I'll now hand over to our chair, Dr. Augustine Asante, Director of the Master of Global Health Program here at UNSW. Augustine is a health economist with years of experience researching in the areas of health, financing, equity and health systems in low and middle income countries. He's worked extensively in the Asia Pacific region and sub-Saharan Africa, evaluating complex health systems interventions, including assessing the impact of health financing and human resources for health reforms on equity of access to health services. Over to you, Kojo, and welcome to everyone.
Thank you, Rebecca. Welcome, everyone. COVID-19 continues to wreak havoc across the globe. The Delta variant has become entrenched in many communities and poses significant challenge to our health systems, and the global economy. After more than 1.5 years of battling this virus, it has become abundantly clear that vaccination provides the only path back to a normal life. Well, if there is anything that can be described as normal life in this day and age. But this is why vaccine equity is such an important and topical issue, especially for millions of people in low and middle income countries who do not have access to a COVID vaccine. We are lucky today to have 4 leading global health experts to share their perspectives on the COVID vaccine rollout and the implications of a global failure to achieve vaccine equity. Please join me in welcoming our panelists. Dr. Catherine Kilbertingi, Executive Director of the Africa Population and Health Research Center, a leading Africa-based, African-led international research institution. She was formerly the Director of Research and has served the APHRC in several leadership roles over the past decade. Catherine is an epidemiologist and alumnus of the University of Heidelberg, where she completed her PhD. She is currently the co-editor-in-chief of the PLOS Global Public Health Journal. Next is Professor Vivek Jha, Executive Director of the George Institute, India, and Chair of Global Kidney Health in the Faculty of Medicine at Imperial College in London. He is also a conjunct professor of medicine here at UNSW Sydney and the immediate past president of the International Society of Nephrology. Professor Jha's research experience and interests include understanding the health and societal impact of non-communicable diseases globally, especially kidney disease. Professor Hasbullah Tabrani is Chief of Party, USAID and Ministry of Health Financing Activity in Indonesia, and Chairman of the Indonesian Health Economics Association. He was a professor and former Dean of the School of Public Health, University of Indonesia. He has a medical degree from University of Indonesia, a Master of Public Health, and a Doctor of Public Health degrees from the University of California, Berkeley. Professor Tabrani was the key person in developing the Indonesian National Health Insurance Scheme, the JKN. Last but not the least is Professor William Pomart. Director of the Papua New Guinea Institute of Medical Research, the country's leading academic research institute. He's a public health researcher with training in immunology and is leading the current diagnosis response of COVID-19 for Papua New Guinea. His major research interests include understanding the protective immunity to infectious diseases among children. He completed his PhD in vaccine and mucosal immunology at the University of Western Australia. He has an adjunct professorial appointment here at UNSW Sydney. Once again, a very big welcome to all our panelists. At this stage, I would like to introduce Associate Professor Anita Haywood, who is the moderator of today's event. Anita is an infectious diseases epidemiologist here at School of Population Health, UNSW Sydney. She leads a program of research aimed at understanding immunization gaps in at-risk populations. Over to you, Anita.
Thanks, Augustine. And thank you to all of our panelists for joining us today. So each of our panelists will be giving a short presentation and we'll be leaving questions for the panel to the end of today's session. So before we hear from our panelists, I'd like to just let our audience know that you can ask questions of the panelists by typing your questions into the chat. And I'd also like to thank our audience members who submitted questions during registration. And so we'll do our best to try and get to all of the questions that you asked throughout today's session. So without further delay, I'd like to ask our first speaker, Dr. Catherine Kovutangi, to present. So thank you, Catherine.
So I believe we are on the first slide, which talks about COVID vaccine inequity and a thin line. And I chose a thin line because from where I sit, speaking from an African country in Eastern Africa, we think that the inequity is so gross that there's a thin line between inequity and vaccine apartheid, which I'll talk about towards the end of my presentation. Next slide, please. So this is a quote from Dr. Tedros, the Director General of the World Health Organization, who says that vaccine inequity is currently the world's biggest obstacle to ending this pandemic. And of course, the pandemic requires many interventions, but really vaccine inequity right now is the biggest obstacle. So before talking about what vaccine inequity is looking like in Africa, next slide, please. I just wanted to show you how the pandemic is evolving in different African countries. So by now, there should be a slide that talks about COVID-19 cases in selected African countries. And on the left hand of the panel are 2 East African countries. I'm from Uganda, but I live in Kenya, so I picked those 2 countries. And then in the middle, we have 2 countries from Southern Africa. And then on the right, we have Senegal, which is in Western Africa, and Rwanda, which is also East African and one of our neighbors. And what is evident from this slide is that all the many African countries are experiencing either second or third or fourth waves. Kenya is at the end of the 4th wave. Namibia has just ended its 3rd wave, which was much worse than the previous 2. The same with South Africa, the same with Senegal. And the pattern is really waves that are just as bad as the previous ones, or waves that are worse than the previous ones. So Uganda has just come out of a really, what I would call a brutal 2nd wave in terms of cases, but also in terms of death. And the next slide, please, shows how the number of deaths have panned out in these same countries. So by now, there should be a slide that talks about the COVID-19 death, and it's the same countries. And what we see, for instance, from Uganda is a first wave that hardly registered in terms of the number of deaths, and then a second wave that was many, many times over, many times worse when it came to the number of deaths per million. But one thing which is striking is that when you look at the number of deaths per million, they're still relatively low. Most of them are single digits, with the exception of Namibia, which is in the middle panel, where they reached about 30 deaths per million, which compared to other parts of the world is relatively low. So overall, much as this is happening in Africa, there are lots of caveats around the numbers of cases based on the low detection rates, low testing rates, and so also the late diagnosis or access to healthcare services. So even as these numbers look low, there are caveats around how accurate they are. And it could be that they're just a fraction of the true picture of what COVID-19 has been in Africa. So the next slide, please. This is looking at what's happening with regards to COVID-19 vaccines in Africa and the global context. And out of the 5.6 billion doses which have been administered globally, at least as of a few days ago, only about 120 million doses have been administered in Africa. And in Africa, only 3.5% of the population is fully vaccinated, and less than 6% is partly vaccinated. And compared to the rest of the world, where at least 30% of the population is fully vaccinated, with 42% partially vaccinated. So, this is one dimension of inequity, which shows that compared to other regions of the world, Africa is really, really lagging behind. And perhaps it could be the region that is lagging behind the most compared to any other region of the world. Next slide, please. So this is a slide that shows one dimension of vaccine inequity. I've just said that from my previous slide. And really what this slide is showing us is that while access has accelerated in high-income countries over time, the trend in low-income countries has hardly shifted. And you'd have to look very hard to look at that purple line at the bottom of this slide, which shows almost a stagnant growth in terms of the proportion of the population which is receiving vaccine doses, and a very clear upward trend in high-income countries compared to low-income countries. Next slide, please. So this slide should be showing the share of people vaccinated against COVID-19 in selected African countries. And these African countries are ranked based on the country which has the highest proportion of vaccinated people, which is the Seychelles. And then we capped it at the number of countries which have at least 2% of their population with a single dose. So in this slide, the number of countries which are there, those are the only countries in Africa which have at least 2% of the population partially vaccinated. Only 15 countries have more than 5% of their population fully vaccinated. Only 20 countries have 5% partially vaccinated, 31 countries more than 2% partially vaccinated. And so inequity comes in different forms because the higher vaccine coverage is correlated with income grouping. And the countries in the top part of this bar are largely middle-income countries, but they're also countries which are able to strike bilateral deals with vaccine manufacturers, especially the Chinese and the Russian vaccines, and who are not wholly reliant on the COVAX initiative. And so what we see are also differentials in access, but they're also relatively rich countries, very touristic. So they were able to put a stop to the COVID-19 pandemic by highly vaccinating the population on top of many other measures. The next slide shows inequity in other forms, but just giving some additional detail, showing that in Africa right now, about 2.9% of the population is fully vaccinated, and some countries have received no vaccine. So even as we see these countries which have vaccinated at least 2% of their population partially, there are 2 countries in Africa which have received 0 doses, but no single country can say they've received enough doses. And many have not received their second round allocation on time. And so it has completely disrupted their vaccination programs. Countries had to put on hold for weeks their vaccination programs because vaccines were not coming. And when they're coming in bits and pieces, this donation here, that donation there, which has completely messed up how countries are able to roll out their vaccination programs. This is an interesting slide about vaccine affordability, showing that high-income countries will only need to increase their healthcare expenditure by 0.8% to achieve a coverage of 70%, while low-income countries have to increase their healthcare expenditure by almost 60%, which is astounding, but also raises the question of where we expect this 56 or 57% of the increase in healthcare expenditure to come from. Next slide. At this point, I think you should be on slide number 10, and that's the cost of achieving herd immunity. Interesting estimates again from the UNDP showing how much it will cost to achieve herd immunity, assuming that many countries are able to vaccinate 20% of their population in 2021, and then the rest of their population in 2020. 9.5 billion needed for vaccines themselves, and then other billions of dollars needed for the service delivery elements of the vaccine coverage. Next slide. So the question is whether we are in the era of vaccine inequity or vaccine apartheid. And at the bottom of my slide on the right is a quote from the President of South Africa, who says that the situation in which populations of advanced rich countries are safely inoculated, while millions in poorer countries die in the queue would be tantamount to vaccine apartheid. And so some initiatives have started with stated equity goals, and the COVAX is one of them. But in the end, they ended up with partial equality, and the current reality really goes beyond simple inequity. This is my last slide. Next slide, please. And the theme for this talk was whether vaccine equity is achievable. And what I would say is that the current world order does not support equity, because the goal of any society should be justice, fixing the system to offer equal access to tools and opportunities. So equity has failed. We've not even availed tools to identify and address inequality, and it will continue to fail because preserving the power differentials by rich countries has been prioritized over equity and justice. So in sum, I think the answer is no, and I hope to hear from my colleagues and fellow panelists about what the situation is like in other parts of the world. Thank you very much.
Thank you so much, Catherine. Definitely opened, set the scene for our talks today. So next I'd like to invite Professor Vivek Jha to present. So handing over to you, Vivek. Thank you.
Thank you, Catherine. And there is going to be some overlap between what Catherine just presented and what I'm going to show. And I think there might be some overlap in what other speakers are going to show as well. And so this is what you already saw. So this is perhaps the answer to Rebecca's first question as to how will we achieve vaccine equity. Vaccine equity will mean taking that box away from beneath the feet of the big guy and putting it in, beneath the feet of the little guy there. So that's what is more important for us to do as the world, rather than to just make sure that we say that we have given the same thing to everyone. That's not how equity works. Equity is not the same as equality. So we are not just giving an equal chance to everyone. Can I go to the next slide, please? Equity has often been framed in moral terms, and as Antonio Guterres, the UN Secretary General, and other world leaders have framed it as vaccine equity being the biggest moral test for global community. But I would like to present to you that it is not just a moral threat. Next slide, please. It really is a survival, an issue of survival and an issue of health. And this is something that Dr. David Foster said, who's a former Sydney Sider, but now in the University of Oxford. And he says that herd immunity will be harder to achieve than we first thought. And Catherine presented the figure of 70%, which was before we had the Delta variant. We now have Delta, and the rules of the game have changed. Now it is thought that we need perhaps to achieve 90% immunity, and that it would take only a small 10% of the world population to remain unvaccinated to provide a big enough pool for the virus to circulate. And if this virus continues to circulate and spread like wildfire in the global south, it will mutate again and again. It is bound to happen. Viruses will be viruses. And there is no way that we can escape from this fact. This is just a medical fact and not a moral issue. Next slide, please. And so what it means, and again, this is a quote that we have heard again and again many times, it is not over until it is over everywhere. But currently, the rich countries are monopolizing vaccine supplies. That is something which again has become clear from what Catherine showed. And next slide. And this is again a version of the same data that you show that high-income countries have been racing away with the number of vaccine doses administered, followed by upper middle-income countries, lower middle-income countries. And the line of the low-income countries is not even visible because it is hugging the x-axis there. And so therefore it is really invisible at all. And so therefore what it means is that the world is following a vaccination strategy that doesn't combat inequity. And as a result, it is further entrenching inequities, really, and that's something that should concern the global community, health community altogether. Next slide, which shows us the number of people in high-income countries who have been vaccinated. So 1 of every 2 people in high-income countries have received at least one dose of a vaccine. But in low-income countries, 1 in 38 have been vaccinated with at least one dose. So that's something which should again concern us all. And this is not concerned just because it's an academic exercise and we as humans are concerned about the plight of other humans. It is going to come back and affect all of us sooner or later. Next slide, please. This is related to the number of vaccine doses procured per each adult. And here you can see countries in different colors. The darker blue shade means that those countries have been able to procure higher number of vaccine doses per adult. And the darker shades of blue means that those countries have procured between 2 and 12 doses per adult of their country. And the size of the bubble is the number of new cases in those countries. And you can see that Australia, North America, Canada, Western European countries have more than enough doses. So they have hoarded doses far in excess of what they need. Whereas you can see the African continent and large parts of Asia are very light. Next slide, please, which means that they don't have enough vaccine doses. You saw this slide already. Affordability is a huge issue, which means that we need to share our wealth. And when we had the G7 summit a few weeks ago, those G7 countries made a symbolic gesture of offering 1 billion doses, which is nothing compared to the demand or the requirement that exists around the world. Next slide, please. And here you see the cost of vaccination and a percentage of GDP of these countries. And again, you can see the countries in Africa, South Asia, Southeast Asia, which concerns us as the part of the world that we all represent and are speaking from in this panel. The cost of vaccination as percentage of GDP is so high that for many countries it is several folds of their GDPs, and they're just not going to be able to afford it until they receive assistance. And that assistance was supposed to be provided by a number of mechanisms. Next slide, please. This global risk sharing mechanism, I'm sorry that the slide doesn't appear as it was intended to. So this is called COVAX, which is a global risk sharing mechanism for pooled procurement and equitable distribution of COVID-19 vaccines. But it has been hampered in its efforts because of a number of challenges. Many countries have imposed export bans, which unfortunately includes even my country, India, which when it was hit by a second wave decided to impose this export ban. Many countries struck bilateral deals between manufacturers and countries, and these are high-income countries, so that manufacturers, rather than sourcing their vaccine supplies through COVAX, actually directly sold their vaccines to these countries. There have been challenges in production scale-ups, and there have been regulatory filing delays, which have hampered the functioning of COVAX. Next slide, please. So, as a result of the AIM's 2 billion doses, which were projected to be delivered this year by COVAX, it has shipped only 251 million. And remember, the goal of COVAX was only to vaccinate 20% of the world population, which is far less than the 90% which we need to get to achieve close to herd immunity. So we know that 24 vaccines have been approved for use by at least one national or national regulatory authority. 18.7 billion doses have been secured globally by COVAX, but only 251 million doses have been shipped through COVAX to 141 countries. And what's important is that COVAX was meant to help low-resource countries, but many of the supplies through COVAX have actually gone to developed countries, including UK, Canada, Australia, and New Zealand, which is contrary to the principles of COVAX. Next slide, please. So vaccine equity is actually undermining global economic recovery. And we know that vaccines work against poverty and conflict by also giving children the same life chances when access is inequitable. And as I said before, a vaccination strategy that doesn't combat inequities stands to further entrench them. So what we need is acceleration in scaling up manufacturing and sharing enough vaccine dosage. And the countries that are not able to inoculate 60% of their populations will lose a huge $2.3 million in the next 3 years or so. Next slide, please. But we have a few things that we can do, to achieve success. We need to establish the right kind of partnerships, not the kind of sneaky backdoor partnerships that many countries have done so. Mutual trust needs to be established to promote vaccine awareness and uptake. We need to identify and reach vulnerable populations. And this is true not only across different countries, but even within countries. For example, in my country, like India, there are many vulnerable people. We need to simplify registration procedures rather than depend on digital procedures, which will disenfranchise many populations which are not digitally literate. We need to leverage data to predict behavior. People should be allowed to just walk into a vaccination facility and get workforce. We need to strengthen and protect the healthcare workforce, use the frontline healthcare workforce that really knows how to reach the population, and we need to establish reliable supply chains. So these are a few things that we need to do more. We need to do this more as a global community, but we need to do this all within our own existing healthcare systems as well in order to achieve global as well as national vaccine equity. Thank you very much.
Thank you, Vivek. Our next presenter is Professor Hasbullah Thrabani. So I'd ask Hasbullah to join us now.
Yes, thank you very much. Good afternoon, or maybe good morning, depending on where you are. I'm going to present the case of Indonesia. Indonesia, one of ASEAN countries in the middle. 2 countries here in ASEAN are scattered across many islands, Indonesia and Philippines. Next slide. Yeah, well, Indonesia actually suffering a lot by the COVID. Can be shown by this graph showing our decreasing revenue from tax revenue because basically as everywhere COVID has halved all the almost all activities, economic activities, resulting in reduction of tax revenue by the government. In the meantime, the government expenses need to increase to intervene to control this COVID. So our GDP drops and our tax ratio also drops. But now this year it's shown increasing, recovering after very hard work last year and early this year. Next slide. Because of the tough to control and a lot of losses in terms of economic, the government's very seriously looking at the option to vaccinate at least 70% of the population by the end of this 2022. This is a picture of President yesterday. He visited every villages every day to ensure that vaccination is undertaken in those villages. So he targeted minimum 2 million people a day must be vaccinated, and the right graph showing the trend of first and fully vaccinated people. So by today, we already vaccinated 72 million people, but that's still only less than 40% of the total population. So our targets remain quite high. Next slide. The biggest challenge in Indonesia is that many people are not welcome with this vaccination. This is the survey of one of the prominent survey institution, LSE, in July this year, showing that 36% of the sample did not want to take that vaccination for various reasons. They believe the vaccine is not good. Majority of Indonesia Muslim countries, some of them say vaccine is not halal. Some not believe. Some also having trouble with their condition, certainly not willing to take it. But this is a very serious challenge for us. While we are targeting 70% of the population should be vaccinated to get herd immunity. Although the government work hard to cover every villages, but the reality is not that easy. Especially we have so many local governments, and each local government are given the authority to undertake vaccination in their regions, province or cities or districts. The national government just dropped the vaccination, purchase vaccination vaccines and drop to them, and they undertake. The city like Jakarta is very good because currently already 100% of the population age 12 to and above already vaccinated once dose. 70% fully vaccinated double dose, and therefore now economy is moving. Shopping malls already opening, requiring vaccination as an entry point. Approval of vaccination, we establish a software to detect that they have to show the vaccination as a passport to enter the mall. That will improve and enforce the vaccination, but mostly in the city. In the rural area, we have challenges. Next slide. If we look at the comparative comparisons, Indonesia and other countries in ASEAN, we can see this graph. Many countries are struggling with the increased sharp after the Delta variants hit severely. In most countries in ASEAN, Vietnam is just beginning. At the beginning, Vietnam and Thailand can control nicely the COVID spread. Philippines not that good, but now every country is having a big increase of this COVID. Thailand's already just having some reduction. Next slide. Indonesia already control this Delta variants. Now the cases are very low already, and the positive rates already below 3% in Jakarta, but nationally still under 10%. So we are in decreasing slope, and therefore the government is very keen to improve vaccination, not to having the third wave in Indonesia. Singapore also are doing the same thing. Singapore already covered almost 85% of the population with single dose and fully vaccinated. And therefore, you can see the graph, the increase relatively small. Malaysia has a problem with that. I don't know what's the reason with this. Although vaccination already reaching more than 50% of the population, but the case increase still increasing. Not good. Probably because of the people still moving actively. Next slide. So the Indonesian government also developing its own vaccines that will be ready next year. In the meantime, we are purchasing from other countries, Pfizer, AstraZeneca, Sinovac, Sinopharm, Johnson & Johnson. Also, we get COVAX vaccine. Till yesterday, we already procured 229 million doses of vaccine. So that will be good enough to cover, because we still have more orders coming. We already ordered about almost 500 million doses of vaccine by early next year, that we expect to cover most of the population which are eligible for vaccination. The goal is to provide equitable vaccination, all free for everyone. And in a big city, they're opening drive-through vaccination in many stores. They can offer, in the mall, they offer vaccination. So to make sure that people can access. The problem is some people don't want to be vaccinated. That's our big problem, is the behavior of the people. Next slide. In the meantime, private sector also involved very much. This is just indicator that Daily News Compass developing the index of how local government handling the vaccination and COVID, just to stimulate the competition among local government. This is a province level. Next slide. The government committed to improve budget. So as you can see here, the government is willing to allow the deficit up to 6% of the GDP last year, and this year still also 5% of GDP. This is a new one, but the government has to do it with borrowing money from people and from others to ensure that there is enough money to cover vaccination and to control COVID up to the 2022. This is the budget that the government proposed. Next slide. I think I'll be finishing. So this is a COVID budget, the orange one, that increasing this year very much compared to previous year. This is Indonesian rupiah, trillion Indonesian rupiah. Next. Yeah, that's conclusion is that we are trying hard to ensure equitable vaccination across different regions in the countries, but we are facing a huge challenge, although the government has a commitment, but if we are not achieved, then we are afraid that our economic growth will be also contracting. Thank you very much.
Thank you, Hasbullah. So our last presenter is Professor William Pommet, Papua New Guinea, our closest neighbour. So I just ask William to please present. Thank you.
Thank you. Thank you for the opportunity to please present figures from Papua New Guinea and on COVID-19 and is equity achievable. Next slide, please. So Papua New Guinea has probably, unlike many other countries, not suffered as much. To date, we have about 18,000 positive cases, of which 17,000 have already recovered. And of that, we have about 194 deaths that are recorded. We know that there might be many more deaths that we are not recording well. But as you can see from the graph on the left, we had a first surge in last year in August, around August, September of 2020. And earlier this year, we had a bigger surge, second surge of COVID. And currently, to the far right of the graph, you'll see a small surge, and we're currently seeing that there might be a third surge on its way. And currently here where I'm working in Goroka, there's already a report of beds already being fully occupied in the hospital. Next slide, please. So what are the main challenges in rolling out the vaccine in Papua New Guinea? And as you can see from the newspaper clips that I put on the pictures, there's currently people complaining about having a vaccine passport to go to work. And much of that is because of the misinformation that is going around. And much of the misinformation is perpetrated by leaders within the health sector, leaders within educated Papua New Guineans who are going ahead and misinforming people. And therefore, this has led to vaccine hesitancy. So there's a lot of vaccine hesitancy among educated plus the rural population, who obviously get the information from people who are educated. So it's a big problem that we have at the moment. And so hopefully later on in this conversation, we'll talk a little bit more about vaccine hesitancy and this problem of ensuring that if you want to have a job, you get a jab first, something that the legal entities here in Papua New Guinea are looking at. And I guess one of the main challenges as well is that in Papua New Guinea, when the vaccine comes, it's concentrated in the capital. Sometimes they forget those of us who are in the province, as well as availability, and something that all our speakers on this panel have spoken about earlier. The availability of vaccine, and currently we're all getting vaccines through the COVAX facility, and at present the vaccines that are in the country are the AstraZeneca vaccine from donation from Australia, also through one manufactured in India, plus the US has only last week provided some Johnson & Johnson, and the Chinese government has also provided some Sinopharm. Next slide, please. So in order to try and allay some of the fears around vaccine hesitancy, the department and the government here have looked at ensuring that leaders in the churches or in the religion space, in spotting heroes, all of that have some say in this Sleeves Up campaign that the health department is currently rolling out. And so in this picture, you can see that this whole people that are now rolling out the Sleeves Up campaign to try and alleviate the vaccine hesitancy. But I can tell you right now that the vaccine hesitancy continues to be a big problem for us. Next slide, please. So what are the main challenges in securing vaccine at the national level? Obviously, global supplies is a big issue, and all of us, the panel here has already spoken about those supplies and the inequity that follows from those supplies, that this vaccine holding. We hear in the news too that there's, many of the developed countries are now looking at booster doses, whereas many of us in developing countries continue to not even have the first doses. So global supply has an impact on how at the national level we secure vaccines for our country. Our economy is not running as well as it should, despite the fact we have a lot of minerals, and so the government needs to look at ways, aside from using the COVAX facility, other ways that we can procure vaccines. We have now received, as I said earlier, donations from Australia, from the US and from China, and these donations are being put into arms. But with the population that we have, the 10 million people that we have, the number of doses are not insufficient for ourselves. And we thank the Australians for also donating to Papua New Guinea and other Pacific Island countries. Next slide, please. And one of the main problems with vaccine distribution within PNG is that the health workers themselves don't believe in the vaccine or in whether the virus is real or not. And so that's part of the problem. And so if they're not going and getting vaccinated, then how do we convince others to go and get vaccinated? So we need our campaign to get people to be vaccinated needs to start at the health worker level. And from there, the vaccine gets distributed to the other first frontline workers like the police, security guards, people at the airports, people in hotels, and so on. And one of the problems with distribution is that 80% of our population live in rural areas. And in many of those rural areas, health facilities there are quite poor. And so you need things like electricity to maintain freezers to support the vaccine. You'll need logistical support for all of these areas to get the vaccine into arms. And because a lot of people are healthy, they ask the question, why should I get vaccinated if I am healthy? So advocacy again becomes a central role in trying to ensure that there's equitable distribution of vaccine across the country. Thank you. Next slide, please. So if the implication for global failure to achieve inequality is that, it won't be only about COVID, it will be about other health problems that we have as well. And that if we don't have equity for vaccination, all the other medicines will have a problem with, and so our health system will suffer. The COVID itself is impacting on other diseases, for example, malaria or pneumonia and other infectious diseases, tuberculosis, HIV. And so if there's a failure, there's obviously going to be, that impact is going to be on other diseases, plus it's going to be an economic disaster for Papua New Guinea. And so for us, like Catherine said earlier, I think achieving vaccine equity is really not possible. Next slide, please. So this is looking at what sort of rural areas that we have, and you can see on the left of your screen is the health facility. That's how poor it can get, and so to get to that health facility, how do you then maintain vaccines? In order to get to the health facility, you got to go through rural areas, and so part of our problem is logistical challenges to bring the vaccine, which something like Pfizer or all of the vaccines require refrigeration. How do you get it from the main ports to the people who need the vaccine? So with that, thank you very much, everyone. I think, like Catherine said earlier, vaccine equity might not be possible if we continue in the way we are at the moment. Thank you very much.
Thank you, William, and thank you to all our panelists for your excellent presentations, really thought-provoking and all highlighting where the inequities are already there in terms of distribution of our COVID-19 vaccines. So now we've come to the part of the session where we go to a Q&A. And so I'd like to first start by asking each of you a question related to your presentation, starting with you, Catherine. So you're part of the African Population and Health Research Centre. So my question for you is, what role do you think these think tanks such as that centre have in steering the discourse around access to vaccines in the African region?
So I think, as you've heard from other presentations, equity manifests in different ways. So on one hand, one of the people that I'm familiar with said we are screaming into the void about vaccine inequity globally. So we have lots of initiatives, social media campaigns, participation in high-level panels, these kinds of things, webinars that we organize, but others, really to create some kind of noise about really that this is unacceptable. So we're doing that, which is more outward looking with regards to how the global community is working around vaccine equity. But then on the other hand, you've also heard that vaccine hesitancy is an issue. So in the midst of scarcity, there's still hesitancy. And so it sort of disrupts the flow of vaccination programs. So we've also been doing a lot about, trying to address the myth and barriers to uptake for vaccines when they become available. So I think briefly, that's what I would say.
Great, thank you. And so my question to Vivek is around what role do you think around the private sector could play in facilitating or achieving equity around different countries to access to COVID-19 vaccine, and to the other panelists as well, if you'd like to comment.
So thanks, Anita. I think at this point, it's really important for the private sector to not think of itself as the private sector, but to work in tandem with public health sector as one. Quite often we have seen an issue of disparate and often misaligned incentives in terms of what the private sector wants and what the public health goals should be. The profit incentive of private sector hasn't completely been taken off the table. So far as some of the COVID-19 related public health work is concerned. And so in India, we have, for example, created a dual or differential system of vaccine availability. In public system, people can get vaccinated without paying anything, whereas if they get vaccinated in a private hospital, they have to pay for it, which creates a dual system. And we've done surveys, and we have found that to actually create a barrier which raises vaccine inequity, even in the most vulnerable population, because they don't have a public facility close by. They have a private facility, but if they want to go there, they have to pay for it. Even some of the vaccine manufacturers, and on the one hand, in India, we're fortunate that we have quite a few vaccine manufacturers, but they have decided to make the vaccines available to private sector at a cost, and the private sector's hospitals then add on a further quote unquote facilitation fee or administration fee, which then they pass on to the patients. And patients, because they don't have access to insurance, have to basically make an out-of-pocket payment for that. This is not a situation that is that should be allowed to happen, especially for vaccination. All the other essential vaccines are available free of cost, and that should be the principle that we should adhere to here in COVID-19 vaccines as well. So essentially, in summary, I just come back to the point that the private sector should subsume its profit-making, should put that in the back burner, the profit-making incentive, and subsume its mission with the broader public health mission of making sure that the populations are vaccinated, because that's the goal. Unless that happens, no one benefits.
Thank you. Thanks so much. So William or Hasbullah, would you like to comment around the private sector in terms of in Papua New Guinea and Indonesia and their role?
Yes, thank you.
Yeah, thanks, William.
The private sector here is quite helpful in that it also wants to help, but they're also at the forefront of trying to have the vaccine passport as part of what the sector works in. So they've been helpful, but they've also been some of those ethical issues that we talk about is probably part of the reasons why they are not as popular. But the private sector is trying its very best here in Papua New Guinea to be as involved as possible in the conversations around vaccine hesitancy and making sure that their workers are vaccinated well as well. Thank you.
Thank you.
Yeah. Indonesia, private sector play a very big role in vaccination. The government allow the chambers of commerce to organize vaccination for the employees of all big companies and small companies. They manage in their own system, but they are not allowed to charge the employees. The employer should pay that vaccination, and the government where the employer pay of the price in order to speed up coverage of the vaccination. In the delivery side, we can see a lot of clinics, hospital, communities providing vaccination. Even drive-through vaccination are in many big cities by private sector.
Thanks, Hasbullah. Now I have a question around, so there's been a question from the audience about TRIPS waivers and waivers of IP for vaccines, but also for treatments and diagnostics. So I might start with you, Catherine. So how would waivers be helpful for Kenya and other countries in Africa?
I mean, I think when I concluded my presentation, I said that, this preserving the power dynamics is the biggest barrier. And I think that's where TRIPS waivers and all the other things come in. When you look at the cost for vaccinating the world, there's no other way that can happen unless the cost of vaccines themselves reduces. And the cost of vaccines can only reduce if there are more areas where the vaccine is being produced, if there are more opportunities to produce it in different parts of the world. And that's only possible if there are TRIPS waivers and technological transfers. So really the whole discussion in the world, the TRIPS waiver discussion has sort of been shunted, and now we are more focused on donations. And we are donating the same doses that exist in the global supply chain and not trying to find ways of increasing production. So I don't think vaccine inequity is going to end unless the TRIPS waivers and the technological transfers happen, so that vaccines can be manufactured in many geographies by different entities in different parts of the world.
Thanks, Catherine. I might move to you now, Vivek, because India was in a difficult situation where, with the big wave that happened recently, deciding to move some of the vaccines that were developed for the low and middle income countries to their own citizens. And so that puts India and other big manufacturers for the global south in a difficult situation. So would you like to comment on how India is sort of managing that moral dilemma of keeping vaccines for themselves, for their citizens, and distributing it globally?
Yeah, that's a very, very important question. And there was another question from a member of the audience in the chat is, why did countries decide to pick vaccines out of the COVAX facility? And that's exactly the argument they used at that time when they're worried. They said we just prioritize our own populations and we don't care at that time what is happening in the rest of the world. It sounds atrocious, but then that's the position that these countries took, including my own country. So in early 2021, when India had come out of the first wave and had started producing vaccines, India was shipping vaccines to many countries around the world, and that was seen as quote unquote vaccine diplomacy by India and as its outreach to many poor countries. And that certainly ended when India had its own second wave and large second wave, in fact. And then we realized that we do need vaccines here in India much more urgently. So and that just goes to the point that we need to ramp up. We need to just increase the total number of doses, as Catherine just pointed out, rather than to just redistribute the same number of doses that are available. And that won't happen just with the TRIPS waivers. We need TRIPS waiver is just the beginning. We need to have technology transfer. We need to train people. We need to set up facilities. Because look, this is not just a matter of dealing with this particular pandemic. As has been said again and again by people who know more about this than me, for sure there is going to be another pandemic in our future. And we need to put in place mechanisms that will deal with this, which is vaccine production mechanisms around the world.
Thanks, Vivek. I've got so many questions I could ask the whole panel, but we're running out of time. We've only got 2 minutes left. So I thought I'd go around the panel and just ask, what is it that you think Australia can contribute to achieving global vaccine equity for COVID-19? So starting with you, William, if you're available, you might have dropped out.
No, I was on mute.
Thank you.
Thank you. So Papua New Guinea is a recipient, I think a major recipient of Australian aid. So we feel lucky that Australia is able to provide vaccines and a lot of health, things to Papua New Guinea, as well as developmental aid as well. So we are quite lucky in that sense. And so if the vaccine were to be manufactured in Australia, and then, I know that it currently is, and there's sufficient vials for both Papua New Guinea and Australia, I think that we will be able to get some of that. And so in many ways, I think we are lucky in that sense. But at the same time, I think having cheaper vaccines as well from other sources would also be quite helpful for us. Thank you.
Thanks. Hasbullah?
Yeah, I think we, not only Australia, we all have to share. I agree with we have all to share of the vaccine to everybody in every corner. Otherwise, it is gonna be a new emerging disease again. It should be treated as a global public goods about this vaccine. Certainly, we have a challenge for that, but we have to pursue that one: global public vaccination.
Thanks, Vivek.
Look, not much to add. I think we need to treat it together as a global problem and approach this as a global community, that we are all in this together. And, we could go back to cliches, but I think they make the point.
Thank you. And finally, with you, Catherine.
Yes, I think we can only address inequity if we all wake up and realize that we are human beings and we all, we all need each other, justice and equity. But unless that happens, and this current power differentials remain the way they are, then inequity really will be what we'll have to live with.
Thank you. That's a good way to end the session. Unfortunately, that's all the time we have. I could spend another hour asking questions because you've raised so many really important issues. But I'd like to thank all of you, our 4 panelists, for joining us today, and to thank the audience for your questions in the chat as well. Unfortunately, we couldn't get to all of them. And just thank you to Kojo and our team at the school for organising today's session, particularly Maya and Ramesh, Ravit, Michelle, and Anil. And for those of you who are interested, our next event will be publicised soon. So thank you very much, everyone, and wish you all a pleasant evening or afternoon or whatever morning for you, Catherine. So thank you, everyone.
Thank you very much.
Thank you.
Thank you
very much.
Bye-bye.
Thank you. Bye-bye.